Hello again in GIS Roundtable. I'm here and the pleasure of hosting Dr. Ahmed Al-Shehri, or he's hosting me, we're hosting each other, I guess. And we're going to talk about kind of an important topic for us as operator for TAVI, about the expansion and the indications for aortic stenosis patients. As we all know that the core of the indications for TAVI started for symptomatic severe AS. However, with the advances in technologies and experience and more of clinical trials coming through the pipeline, and the one who was recently published, the indications has been expanded. So I just want to have your take on this expansion in terms of indications.
I totally agree. Thank you very much, Muhammad, and the GIS group. So I totally agree that we are living now in a new era of expanding the indication of the aortic stenosis management. So now we know, and we have a good evidence that we can take care of the asymptomatic severe aortic stenosis with percutaneous intervention, and what would serve the patient the best outcome. And now the question that it is very important to highlight is how many TAVI platform or transcatheter aortic valve platforms you have to have in your cath lab. My take about it, being the director of the cath lab and the structural person in my group, that I have to have two platforms. One is annular and one is supraannular, and also I have to have one platform that is balloon expandable versus self-expandable. So what is your take?
Yeah, I totally agree. I think limiting yourself to one type of valve, I don't think you're doing yourself a favor or the patients a favor. I think having the options, I think it's very important for a successful program, to be honest. Either supraannular, annular, balloon expandable, self-expandable. I see operators that limiting themselves to one platform, which is kind of, to me, not the best practice in terms of being a cath lab director, to have just one option. So in that aspect, totally agree with you. Moving forward, we're going to see this debate over and over, annular versus supraannular, and it's just going to keep changing. The opinion's going to get stronger, but I think back in our mind, we should not have solo players in all kinds of medicines, let alone a complex disease like severe AS. Coming back to the indications for the TAVI, as you will know, in the recent update of the ASC guidelines, that the age cutoff dropped down from 75 to 70, irrespective of the risk. However, people are more talking about asymptomatic severe AS and also symptomatic moderate AS. So what is your take on these two groups?
Thank you very much. So now the real question is that we be taking care of younger patients, and the lifetime management of these patients and this group of patients is very important. So you are not just thinking and planning for the procedure itself, you're just knowing that you will be visiting this valve in 10 years time or maybe longer. And so things that is very important, so the ability to have a TAVI in TAV in the future, the commissural alignment, and getting the best depth to balance between the risk of the conduction abnormality and the risk of occluding the coronaries in the next TAV and TAV. So it is very, very important to set for this key patient population, to set and to think of the ongoing procedure and in the future procedure too, in order to serve the patient to the best outcome.
Yeah, absolutely. And we know from the evidence that watchful and waiting may be not the best strategy for severe AS, even in asymptomatic, based on the early TAVR trial, as well as patients. Maybe there is a hint from observational data regarding symptomatic moderate AS. That's also there is a harm of leaving them without close follow-up and maybe intervention. But there are studies on the pipeline for that, but yet to have a clear clinical trial. So I think the field is progressing. And I think we're going to see more and more based on the technology that's skyrocketing in the TAVI world. With that, I thank you for being here today. Any final comments?
Thank you very much.
Thank you so much.